right, so can you hear me? Yeah. We've had some really thought-provoking insights and discussions already. I do want to open it up to the floor, but first I have one question. And perhaps I'll start, since you're next to me, Brian, I'll start with you, but I'd like the rest of the panel to join in. Given that we're halfway through the workshop, what is the one key consideration, the nugget that you think that any entity who wishes to communicate effectively about obesity solutions should take into consideration, should keep in mind?
Now I'm leading in the direction of a more interesting nuance about the information processing style of the consumer of that information. So there's a tension that we haven't touched yet between what's suggested by what Brian has just said and what was said earlier, that actually the blind factor here is the specific information processing constraints of the medium itself, both in terms of cognitive load, in terms of how much information is contained, how much information you can contain. Sorry about that. Better? But in terms of cognitive load, in terms of how much information you can contain in those media, and also in terms of the kind of communications that occur on that medium. So if you're in the domain of competing against memes, then, and you have not considered that, and you're trying to let's say, promote something that's fairly dry and that requires a fair amount of information processing, you cannot compete, and you will not compete by virtue of contrast. So we really are obliged to get down and do the research necessary to understand that information processing. Some of it already exists, and to tailor content accordingly. Marketers do this. The government should do it as well. I mean, my head spins when people talk about snackable content with trying to sell someone sneakers. But at the same time, that format is the dominant format. Therefore, if we miss that point, we will miss that audience.
Well, I think in my line of work, the most effective communication tool that I've seen is telling your story. I think Patty, every time I come and see Patty speak, I leave just knowing a little bit more about what a courageous and fabulous woman she is, and the struggle she goes through. I mean, when I'm on Capitol Hill, we bring people up there, we ramble off statistics, and the health legislative assistant starts glazing over, and then the patient starts to talk about their struggle, how many times they've tried to address their obesity, all the different things they've tried, the amazing hurdles they've had to go through to get care, and I think that leaves a profound impact. You're going to be hearing a lot about two twins this week, Jill and Meg, who are 34 years old, and these are two twins who worked for the same company in Massachusetts. Both of them moved down to Kentucky because of their job. A year later, one of the twins moved back to Massachusetts, so you have one in Massachusetts, one in Kentucky, and they have done everything literally together since the very first moment of life. And they both are affected with severe obesity. And they both had it. They had tried everything possible under the sun to lose weight. They would address their obesity, but the weight would come back. So they did some research and said, we're going to try bariatric surgery, and we're going to do it together. I mean, talk about the perfect support system for each other. And then when they started to research it, they found out that based on the geographical location where you are in this country is going to deem whether you get care or not, because they looked at their employer plan and it doesn't cover bariatric surgery. While the woman in Massachusetts, they both said, well, let's go off the employer plan and enter the Affordable Care Act, the state health care exchange. Well, Massachusetts covers bariatric surgery for the state health exchange. Kentucky does not. So that was a year ago, and we're looking at a situation where Jill, up in Massachusetts, had her surgery about 6 months ago and has already lost more than 80 pounds, whereas Meg in Kentucky has not had her surgery, and she is looking for different avenues to get surgery, but she has these roadblocks, and she still talks with her sister every day. They try and be supportive. Meg even tries to kind of follow the diet that Jill's doing, but obviously it's built for a different physiology once everything is rerouted and changed. But we want to help these people, and I think, to look at, you've got apples and apples in this case. Two twins based on where they live is going to determine how they get their care. And when you can humanize this issue and have people feel it and make it personal, that I think is our most effective avenue. And I think the James Corden piece, as I said, it's been amazing. That's the biggest thing I've seen in 20 years in this business, of moving the needle a little bit.
Mm-hmm. I think what keeps coming through to me is, from Adelaide's presentation, from your presentation, is this idea of trust. And I think the James Corden response was such a genuine response. It was heartfelt. You could tell it was heartfelt. He had lived this experience, and people can trust him now. And I think trust, building trust in advocacy, building trust in everything you say, helps cut through the confusion, helps cut through the noise a little for people living with obesity. But people are looking for trustworthy sources these days. They're hard to find, and I think that's why they're turning to their peers, because they trust their peers more than anything. But that's one of the pieces of the sessions this morning that has really stuck out to me.
The thing I'd add, this I think builds on the remarks, is that I think one of the central paradoxes of our age is that we're awash in information. So clearly, we certainly must have a sense of what's out there, at least in the environment. And I think that there's this illusion that we actually understand the hearts and minds of people because of a sense of what's on Twitter and what is in mass media and what people must be exposed to, and or what we're seeing people do and respond to in terms of contemporary advertising and all of that. And I don't think it's fair or appropriate for that to be absolute forecast of what's possible in terms of engagement with people. And I think that's, to me, one of the takeaways that I think is very much fits with our session earlier this morning and here as well, is respectful ways to continue to have hope and belief that there are ways of engaging with audiences that we don't need to cynically assume won't work because of what we've been led to the conversation we've been led to have at this point. So for me, that's one of the reasons it will take a lot of faith and effort to reach folks. It's not going to be a matter of snapping our fingers and all of a sudden being a trusted source when we haven't been. It's not going to be a matter of just ridding the universe of all of the other pieces of distracting information that's out there. But I do think there is a path forward.
Thank you. So we have time for a few quick questions from the audience, so please go ahead.
Hi, I'm Stacy, and I'm a student pursuing my MPH in nutrition, and I'm also a mom, and so I think about obesity and talking about obesity quite a lot on a number of levels. And my question is about unintended consequences, and I'm also, I wonder about the numbers that you all might have seen about disordered eating or eating disorders or whatever we're calling it these days. As communicators, are we talking people into eating disorders? And as Brian said, Brian Southwell said, correction is hard. And so if we are going down that path, how do we course correct?
She mentioned your name.
I know. I'm on the spot. Right. I thought you all might pick up on that, which I appreciate. So I think you're right to worry about unintended consequences, and I think that's something that Rebecca's work and others thinking about stigma. This is something that goes with the territory, and we haven't paid enough attention to that over time. And it could be part of a larger holistic conversation about healthy eating and about. So I do think that just that notion being at the table makes sense. It's a complicated issue. I think I could imagine if our response to the rise of disordered eating was to then meet that with another communication campaign, I could imagine that also being problematic in its own way. because there are what's so challenging about doing work under the label of communication is that you have an opportunity to have some influence, but you are intersecting with systems that are about more than information as well. So in a situation like that, it may well be, maybe there was a tipping point moment where somebody tried a particular pattern or habit, but then you're into a realm of physiology and chemistry and other, it wouldn't be fair to say that we're going to undo this with a corrective message either. So I think part of it is to recognize that we may well be able to spark certain moments of discussion, but we have to have a more multi-level perspective on how everything fits together, and how particular aspects of the physical environment and all that as well. So that probably leads us to a policy level discussion as well on that. But I don't know if it's it's at least an initial response to your question.
I can just say I'm the attorney in the room. I'm with Chris. I don't know the research in great detail on this. I think it's something to be considered, and it certainly is an issue that some organizations have brought up, is that talking about obesity and the diet culture fosters eating disorders. I don't know if that's true. What I can tell you from my personal experience is that I'm a binge eater, and it wasn't diet culture that caused me to binge eat. It was more the shame and blame, which some people would say comes from the diet culture, but I don't actually think that. It was now focusing on health. Nobody talked about health. When I was growing up, it was, you are fat, we don't tolerate your fatness. You are a bad person. I probably binge more in response to that than anything about related to any particular way of eating. So I don't know if that helps you. As I say, full disclosure here, I'm just talking here.
It's, as always, there's unintended consequences with any time you try and treat obesity. We went through it with FDA. I think I was talking about where, they had expert panels that had no obesity experts on them to begin with, and the whole discussion focused on, wow, look at all the risks. Your blood pressure could go up. You could have cleft palate in your child, and it was all like, well, what happens if you don't do anything? That's unacceptable. What happens, you're going to take these drugs for long term. What happens when you stop taking them? Well, you're going to regain the weight. It's just like, with cholesterol drugs and such. But, I saw one reaction where they were, with topiramate and naltrexone, where the discussion was, topiramate can give cleft palate in pregnant women. So they told people who have had migraines, because topiramate is, I think, epilepsy and migraines, that you need to stop taking this drug once you become pregnant or planning to become pregnant. And the initial thought was maybe we should ban women of all childbearing age from even getting the drug for obesity, because if you're fat, you must be stupid, which is a hard thing. But that is, the general feeling was, well, we got to be extra careful with this population because they're susceptible to, suggestion, and we're going to protect them from themselves. And it was frustrating, and we worked very hard on FDA to make change and understand benefits and risks. But I'm afraid we're not doing anything in many cases, and a lot of barriers still remain. The preventive care stuff, the fact that, whenever you look at your health plan, you pretty much have no idea if you have obesity screening or behavioral services, because you always go to the exclusion section and it says we don't cover anything having to do with obesity. Or they might say, check the USPSTF thing, and nobody's going to do that. Or they'll say you get to see a dietitian once a year, and that's bunk. We know that from what the task force said.
So unfortunately, we're actually out of time, but we do have...
Did I filibuster?
We do have an opportunity for questions, so please save them. The second part of the workshop actually will have a longer period where we'll have some of our panel back up here, so you can ask questions. The next thing that you all can look forward to is lunch, and I've been asked to please have you back here promptly at 1 p.m. And also, if you are a workshop speaker or part of the planning committee or roundtable member, you'll be joining us in the West Court. Anyone else, please have lunch in the cafeteria, and we'll see you back here at 1 p.m. Thank you.